I'm Angela Adams, the CEO at Inflow Health.
I'm Candice Garcia, CEO of Tungsten QI Partners and the QI Director for the ACR Learning Network.
Our guest today is Dr. Clifton Watt, a practicing cardiologist and executive medical director at UCSF. Before medicine, Clifton trained as a software engineer and has a unique perspective that shapes how he sees healthcare challenges today. Today, we're talking about what happens when innovation outpaces implementation and what it really takes to redesign access to care in a complex health system. Clifton, welcome to Success in Chaos.
Thank you so much for having me.
Absolutely.
Appreciate it.
So tell us, you're a practicing cardiologist, you have software engineering in your background. How does having one foot in clinical care, one foot in technology kind of shape how you see healthcare and maybe the chaos that comes with the healthcare system today?
That's a great question, Angela. I definitely see the chaos. I think that is inherent in healthcare, in clinical medicine. It's just part of what we do um, every day. And so I think that's something that we as clinicians have to accept and, obviously, adapt as we see patients and take care of patients. I think the sort of the unique perspective with regards to technology is that, in my mind, my opinion only, is that technology tends to be a much more organized, less chaotic. It sort of makes sense to us, right? I mean, we're writing a software and it does what it's told, or we're creating a platform, and we're designing it to do a certain thing. And I think this sort of concept of merging technology with clinical care is a really fascinating um, exercise because, in one sense, yes, we have the craziness of healthcare practicing healthcare, and on the other side, we have we're trying to sort of make technology make our healthcare lives much easier. And it's this sort of clash, and this clash between chaos and more sort of um, organizational methodology that technology has. And it's a challenge because there's so much of healthcare that we cannot predict, cannot control, but we are trying to control it with technology, in my opinion. I mean, we're, again, trying to utilize or incorporate, ambient listening technologies and, make our workflow simpler and easier. We're using technology to better operationalize our billing and our referrals. And so, like, the concept is to try to make our healthcare lives more organized and easier and make sense. It's not always possible, but I think we certainly still try.
Yeah, there's such a difference from the lives we live outside of the hospital and then coming to work as a healthcare provider or a staff member. And it's almost like you get stripped of all of the technology that you use in your normal life. And I think there is an expectation that this should be easier. There should be tech that's here for me. And what I'm hearing you say is that, like, actually UCSF is fairly ahead on AI. I mean, you have enterprise chat GPT, you have AI scribes, fairly like early adoption of these like system-wide technologies. And yet there are still things like scrubbing PDF referrals and answering emails from staff manually that, you know, it may feel like to the staff like we haven't actually made a lot of progress. How do you, how does that gap like of innovation actually meet the front line? Like how do you make enterprise decisions and also address the things that they're facing and make their lives easier?
That's also a great question. I think that's the question of the day or the year or our technology lifetimes. I think we definitely in healthcare want to innovate. So if we're talking about sort of in the clinical realm, innovation is a buzzword that we use. We want to innovate because, in many ways we understand that we tend to be stuck in inertia a little bit, us in clinical medicine. And so innovation is one way for us to, to deliver more efficient healthcare, but deliver it also better and more effectively. And so there's definitely an interest. It's just there's so many layers in healthcare and so many stakeholders, right? So patients, providers, physicians, nurses, nurse practitioners, technicians, etc. The hospital administrators, the middle folks, the payers, the insurance companies, the government. There's so many layers that each have its own stake in the whole flow, and I feel like that's part of the inertia that makes it difficult for innovation to go from the tech company and the product to being incorporated. Your question was how do we do it? Yeah, I mean, I think that's the challenge. I think healthcare systems are opening up, sort of, in many different ways, opening up to being ready to better incorporate those innovations. Groups like chief innovation officers, or leaders like chief innovation officers, and governance groups, and groups that really look at the technology out there and say, yeah, these are the technologies that we want to adopt, and we have to make sure there are guardrails, but also to have a use case and a business case for these technologies. I feel like that's something that has really evolved, that didn't really exist. These sort of innovation groups, or a push for innovation. It just wasn't there maybe 10 years ago, and I think that has been a change. So I think, there's a gap, there's inertia, but I feel like the time now, with how powerfully technology has impacted already what we do clinically, I think that has caused the movement to narrow that gap, if you will, to have even some of us on the front line see some of these technologies, even when we thought, gosh, in medicine we are dinosaurs. At least that's the stereotype, perhaps. That the doctors don't, or they're slow to adopt new technology. I think now, with healthcare systems saying, yeah, this is what we are going to have our doctors do, and it helps you too, the doctors and the staff. It's going to make your life easier. It's going to make you more productive. I think all of these concepts are narrowing the gap a bit.
I would love to dig into a couple things that you said there that I think are really important. Candace and I have had a lot of leaders here on Success and Chaos, and they've said similar things where it really, like you said, 10 years ago, was innovation really as big of a push? I think 10 years ago, quality was a big push because it was being driven out of the Affordable Care Act and a lot of the legislation in there that was pushing hospitals to give better care, value-based care, kind of changing some of the payment and incentive dynamics. And so much of the health system back then, um, I was in a healthcare AI company back then, and everything that we had that we were delivering to hospitals was around quality. It was around readmission reduction programs. It was around heart failure programs. It was around how do we predict so that we can prevent things from happening, whether it was sepsis or a fall or a pressure injury. And all of these were tied into quality metrics that were very much tied with the Affordable Care Act. And then COVID kind of changed everything because a lot of the quality metrics that were being required by the Affordable Care Act and these dynamics that were penalties and incentives programs were all paused for almost a total of 3 years. So then, coming on the opposite side of that, what was happening is the hospital was trying to recover. All during that recovery, it was the AI age was right in the big swing of things. So it's like then I think it's interesting that like quality drove innovation a decade ago. Now, innovation for the sake of efficiency is really what's driving demand in hospitals. So, like ambient listening and making sure that your physicians are not spending, what is it called, pajama time, where you have to spend 6 hours like documenting everything you did that day. That's just like torturous. And so, there's a lot of things driving that innovation spirit today. Something that Candace and I see a lot and hear a lot is that the ability for a health system to make decisions quickly with a governance structure that supports a multidisciplinary committee that can quickly come to a realization that they have a problem, understand what solutions are there to solve that problem, understand who they need on the team to make a decision on what they want to use moving forward, and then going into a complete rollout plan and an implementation is really what sets apart health systems for success in the next decade or failure and lagging
Mhm.
behind in the next decade. So I think it's interesting. UCSF has always been on the front end of that. And I would say cardiology as well. Like all of my cardiology friends, that's where I grew up. I was cardiothoracic at Duke. And cardiologists are data driven. Like they have always loved data. And I would say between cardiology and radiology, those two have always been very much innovation, data, technology driven specialties. So if we talk about cardiology specifically, where do you feel like cardiology is ready for disruption? Is it in facing intake, chart summarization, referral triage, like pick out of the hat. Like, what do you feel like in cardiology today is ripe for disruption that you feel like not a lot of people have touched yet?
I think that's an amazing question, and we'll see if I'm right here. I think in a few years, yeah, I think there are two things, two areas that I think are major. One may not be unique to cardiology, and sorry, is not unique to cardiology, and that's access to healthcare. And so, I mean, a lot of the specialists out there are struggling because we are dealing with so many patients needing to come in and see us.
Yeah.
And that's not unique to cardiology. It's just a healthcare problem. And so I think that's a bottleneck. That's an issue that I think technology is really well, you know, equipped. We are well equipped to use technology to disrupt this problem, whether it be to optimize referrals, better triage referrals, make sure that the patients who really need to see a cardiologist should be seeing one. Um, um, chart, you know, chart summarization makes our lives easier, and I think that's an important. It's an important tool that I think will develop pretty quickly because that goes along naturally with some of our ambient listening tools and our tools that are patient encounter based. So, listen these tools listening in on our conversation, helping us with documentation and summarizing, the medical record. But anyways, back to access. I think the access really is ripe for disruption when it comes to technology helping us with the whole process of initial referral to records, transfer to records review, um, and that's hopefully going to help free up the bottleneck. The other thing that is, I think, in my opinion, more unique to cardiology is the way we see sort of low touch, low acuity patients in our clinic. Let me explain. So, we in cardiology, we can have patients with high blood pressure and patients who are, stable, they feel fine, but, they may need some sort of minor medication adjustments when it comes to blood pressure or lipids. Um, this, I feel, is a situation where we as cardiologists, we can take care of these patients, of course, but we also can defer this or have our primary care colleagues help with these patients. And that can help free us up for patients who have complex cardiac disease. And so if we as cardiologists are seeing, lower acuity patients, it kind of limits our ability to 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 have the higher complexity patients, having them seen, referring them for procedures, um, that type of thing. And so, uh, I think what is unique in cardiology is that we have, very simple patients, we have very complicated patients, we have patients who, you know, have problems that can actually be taken care of primary care, but perhaps patients have less trust in their primary care doctor and they want to see a specialist, even though they don't necessarily
Yeah.
need to see a specialist for hypertension or dyslipidemia. So I think this is something in cardiology where I feel like we can use technology to help with managing those low acuity patients and sort of take a little bit off our plate. Using, just throwing it out there, wearables, to intelligent wearables, so
Mhm.
that can monitor blood pressure and heart rate and can deliver sort of more regular advice, perhaps even recommendations, without us being so intensely involved in the care. Obviously, we're going to stay in the loop as the provider, but um, you know, sort of changing more routine cardiology care into, or moving it into the ambulatory, non-clinic space, somehow, it could be with wearable data, could be with remote monitoring, telehealth, that type of thing, and freeing up our time as cardiologists to have patients come in to clinic who have more acute problems or have higher complexity of problems. So that's what I feel like I foresee. Again, we'll see if I'm right, but the future may be that, a lot of care that, we see now, patients coming into the office to have their blood pressure checked and their hypertension managed, that's going to be moved out of the clinic and more into the sort of the, the prevention slash, sort of remote monitoring
Yeah.
space.
Yeah.
So we'll see.
I love this framing because it really is. I mean, where I live is the intersection of technology and quality and change within a system. And what I'm hearing you say so clearly is that innovation actually lives in our ability to evaluate what we're doing, redefine roles and responsibilities. And it's not just the tech that will support the new processes, but it may be a preventative care unit. It may be redefining primary care. It may be utilizing remote technology in place of an appointment. And so it's a real shift of who cares for the patient, where and when. And what I love about where we are right now is like, that isn't just, oh, it's yours, it's yours. Okay, no, it's yours now. It's yours supported by technology. Who has technology that can support these processes, that can replace some of these roles, or supplement some of these responsibilities that we historically have done in person, because that was our only option, person to person, face to face. But now we have all of these other types of solutions, and integrating these solutions is going to require a deep understanding of who I am as a cardiologist and how I should spend my time, and where that expertise lies, and where is it not necessary, and where can somebody else do it, or we can use technology to do it. Those conversations, I think, are really what is coming out of this technology implementation. It is what is out there and what's working and what's available, but it's also, how does that get integrated into our system, and how do we transform the way we provide care in order to make space for
Yeah.
these?
Totally. I totally agree with that. I think it makes what we're doing really exciting. I mean, I think even the next 5 years are going to be transformative, because I don't think we as global, as healthcare, everyone, I don't think we can stay how we are now. This concept of, oh yeah, see your doctor once a year for an annual checkup. That's I mean, one, how useful is that? And two is, we have much better ways to maintain contact with your provider. Again, blood pressure monitoring, transmitting that data, getting more frequent recommendations, updates, evaluations, rather than just once a year, I think what's how our world is going to change, whether we like it or not. And all our devices that are consumer devices now, I mean, we're already getting all that data and questions about data, from patients. Well, what does my smartwatch data show, not related to an appointment, but it's telling me my SVO2 max is dropping, from my watch. What do I do about this? Does it mean anything? I think it's, as you said, Candace, it's going to be key how we deal with this, and how we transform ourselves as a healthcare society. We can't stay put, because we've just got too much change, too much data, too many patients demanding, oh, this is all the information, new information that we have. What do we do about it? We've already gone the way of, of all the wearable data, and, now we have it and we
Mountains
have
of
to be able to
data
deal
and
with
no
it.
one knows what to do with. It's interesting because yeah, yeah, yeah.
Cardiology.
If you travel a lot, I know the current administration has pitched this concept. I'm not sure if you guys have heard, but uh, I I was in France last year traveling, and we had to go to the doctor for my husband. And the doctor, instead of like writing, like gave a recommendation for what labs to do and what, but wrote a recommendation for the pharmacist to then prescribe. And so when we showed up to the pharmacist, we didn't have a prescription from the doctor. We had basically a guidance sheet that the pharmacist looked at and was like, "Oh, okay, this is what you should be on and this is what you should take." Then we were traveling in Belize, same thing happened. The pharmacist actually was the one who said, "Oh, okay, what's going on and what are the symptoms and what's happening? Okay, this is what you should be taking and let me grab that for you." That's what's being pitched by the current administration is primary care also has an access to care problem right now. Some health systems are seeing like 12 to 16 waits just to get a patient an appointment in primary care. And I know for cardiology, it's much longer than that at a lot of health systems. But even for primary care, the wait is long. So it's like, okay, then who does this go to next? And it's like, could somebody with a simplistic, I call that simplistic, high blood pressure, right? That's very common in the United States, or hyperlipidemia, like, could they just go to the pharmacist and they read, like you're talking about, their wearable device? They understand what their running totals have been. They understand what's been tried, med reconciliation, if you will, and then they could actually prescribe an adjustment. So I think that's an interesting concept that we've never really had here in the United States is could you just go to the pharmacy and could they make an adjustment? And you wouldn't have to then go to a backlogged primary care or a backlogged cardiologist appointment. And it would help alleviate and bring those like higher acuity patients to the top of the list for both. So what's your thoughts on that?
I think that's a great point. UCSF, I think, has been already ahead a little bit of ahead of the curve a bit in this area, um, in the sense that, using the same example of high blood pressure, we have multidisciplinary teams. We have pharmacists. We have um, um, advanced nurse practitioners who can make decisions and give recommendations about blood pressure and chronic disease management. And their availability is, typically better than ours as physicians. So they can do these quick visits. So I could start seeing a patient for high blood pressure, and then I can have that patient follow up with the pharmacist for blood pressure medication management. And and so if it's as simple as titrating a medication, yes, we have our pharmacists who are amazing. Um, they can titrate meds. They can talk about medication side effects. They can evaluate for medication adverse effects too. So yeah, I feel like this concept of having a team, and not just go see the doctor, having a team with different members who can help with these types of chronic disease management. That's I think that's for for the future, but we're already doing it in some institutions like mine. And then yeah, the I still I mean, obviously we still need to keep humans in the loop, but I think our devices eventually will be able to give us advice. I mean, that's a little bit, risque to say, I know, but I mean, this is, if we're talking about blood pressure, medication titration, looking at simple trends, I mean, our devices, our edge sensors, I mean, they're going to have AI stored in it. Our wearables, won't even, will be able to make decisions even on their own. Uh, Again, not that we're just listening to our devices, um, but who knows? Maybe I mean, this we're talking about low risk situations where potentially we're talking about adjusting medications for. We're not talking about making diagnoses anew, but adjusting medications um, and having safeguards and algorithms on our devices to do this. Um, I think why not? Again, we're going to have humans in the loop, but you know, I think it's a pretty simple thing to titrate an amlodipine from 5 milligrams to 10 milligrams with minimal side effects, and you know, that's something that can be monitored quite easily, um,
Seen,
remotely without a doctor's
have you
visit.
seen the
Yeah.
patients change over the last few years? Like, used to be they would go to Google and ask questions and probably come to you with, well, Google told me. Now it's LLMs, Claude, ChatGPT Health, Perplexity, you name it. How has that changed the conversation in clinic for you with patients? Like, are they bringing you relevant information that then you have to weed through, and how much more complex does it make the visit?
It's definitely a reality now that, um, whether we like it or not, whether patients can also say, no, we don't do this. And they oftentimes do. They preface and say, oh, I'm not that person. Really, today that happened to me with a patient. I'm not that person who goes on Google and looks up my medical conditions. But they do. But they do. They say, but I looked it up. But and again, and and more than just Google, more,
Yeah.
you doing an AI chat and trying to figure out my problem. And do I blame them? You know, I have family members who do the same thing. So, it does make it difficult. I think. I think. Uh, uh, I know this. We're talking a lot about technology. I still don't think technology can supplant or replace humans'
Yeah.
ability to make diagnoses. Still, at this point, and certainly not make advanced decisions. And yeah, I can be wrong. I mean, we see it all the time, all the time. Um, so if patients are listening to this, I mean, that's what I would say. I mean, the AI is not always correct. That is absolutely true. So it does make our jobs in general, I would say, a little bit more complex in the clinical realm,
Yeah.
where
It
we
probably
are, yeah, we have to, we have to reorient and correct and
Mm-hmm.
say reassure and say, well, what chat GPT, not to any AI
Any of
chat,
them. Yeah.
any of them, told you, that is, that does not need to keep you up at night. Um,
Yeah. It feels like, the transformation is not just about implementing it, but even if you don't implement technology, you are still learning how to change your practice as a clinician to integrate technology, to integrate the access of information that you have, that your patients have, and the expectations. I think that the complexity of it is so like multidimensional that actually like your experience as an engineer and a cardiologist and now kind of a leader in your healthcare system, it requires this level of perspective. I think outside industries, when our clinicians are trained in other fields, it really does bring a different perspective to where we're at and lets you meet the moment in an innovative way where you can really question, what am I supposed to be doing as a physician and what can I let technology do and how do we bring these two worlds together? It just is a really interesting place, and it feels like your expertise is really kind of meeting the moment. Um,
I think so. I agree. I mean, we meet. I as well as the some other members of my faculty meet with our ambient listening tool team once every 2 weeks, and we have to reorient and say, yes, well, if your tech timeline is, oh, we're gonna you know have this feature turned on in Q3, we have to say, well, patients are not going to wait for Q3. We cannot wait. This has to be implemented now, because if we're talking about medical documentation or clinical workflows that matter, that are 24/7, if you will, um, like we have that perspective that the patients won't wait or they can't wait. Clinical time doesn't wait for a company timeline. That's just one example. So totally agree that we are setting, we as providers have to set expectations. And when you're a provider and know about the tech landscape, it's definitely a good perspective to have, and probably will be more and more important as
Well, we have
time goes
loved
on.
having you today. We wish we
But we'll
could
see.
talk all day, honestly. if you could leave us with what are 2 or 3 resources, books, articles, thought leaders that inspire you right now? We always like to close with this, and it gives our audience kind of something to look forward to.
Yeah. I think one person that inspires me actually, and this this might surprise some people, but I would say Mark
Interesting.
Cuban. Um, and Mark Cuban, you know, I feel like he's been really passionate about healthcare reform. And, we all know him as this super wealthy person who is really charismatic and is on TV. But, but he, his low cost drug program and his ideas about healthcare reform and healthcare really, you know, being much more complex and too complex uh, to be able to help the patient and the provider. I think his ideas about how the healthcare system has evolved into this beast that is unwieldy and doesn't help a lot of. I mean, it is a mess. I mean, he said it during interviews. I feel like he understands, even though he's sort of that famous wealthy guy who is known for a lot of things, but he, I feel, has a finger on the pulse um, of providers and patients. He's definitely against, from what I've heard from his interviews, he's against the insurance companies that harm the well-being of patients and providers. Having prior authorizations that delay care or prevent tests from being covered. He's been opposed. He's been really vocal, against that. He's been really vocal against the idea of profit being at the center of medicine. So I think Mark Cuban has been an inspiration. I like to hear some of his interviews with some of the national thought leaders, and would recommend anyone sort of listen in on some of the discussions and chats that he has with folks. And his low cost drug program, I think, is, I've had patients who have used it, and it's really been helpful for patients. So yeah, Mark
Yeah,
Cuban
That's
is
awesome.
my guy.
Good. Love it.
I love that. Thank you. Yeah, that's like innovation, like right there. Meet the market, meet the patients where they're at, and do what's right for everyone involved. Well, thank you so much for your time today, Clifton. It was so great to speak with you. And thank you to our audience for joining us on Success in Chaos. Be sure to like, follow, and share today's episode on Spotify, Apple Podcast, YouTube, or wherever you get your podcasts. And a special thank you to the InfloHealth team for their production support.